I think that's a model, number one. Number two, that model appears to be appropriate. Number three, it duplicates what we saw in the UK with this variant. So I'm not surprised at all. And this is what a virus, when it is in an exponential phase, does. So seeing doubling every 10 days is concerning, but likely real. And my concern for America is that we've just come through all the post-holiday highs, and we had some really high levels of hospitalization cases and deaths. Now they've dipped back down. People are weary of COVID, and they're likely to start skimping on wearing a mask or distancing and not getting together in groups. And if they do that, in the face of these new variants, the UK is just one of them. There's a South African and Brazilian variant, as you know. It's likely to cause another spike back up in hospitalizations and deaths, unfortunately.
Yeah, I know there's been kind of conflicting reports. I know the UK one, they've suggested it may be more deadly, but do we have more evidence involving if it is likely more deadly or not?
So in the UK, the best estimate is that it was somewhere around 28 to 38% more deadly. So those are hard numbers to tease apart, because the larger number of deaths are due to increased transmissibility. In other words, if you hold the death rate constant, but you increase transmissibility by 50%, you get many more deaths than if you hold transmissibility the same, but increase lethality by 50%. It's a hard concept for people to understand, but it's the transmissibility of a otherwise lethal virus that really accelerates the number of cases, hospitalizations, and deaths.
Okay, so it's not necessarily causing more severe disease in people.
We don't have good evidence yet to suggest that. However, I am suspicious it does, because the best guess, as I say, is that the lethality rate is increased, number one, and number two, that the viral loads in these individuals may be higher. Both of those would be markers of more severe disease.
I know CDC is, their modeling is predicting that this could be the predominant strain in the US by March. Do
Yes.
you agree with that estimate?
I do. It won't be the only one. And of course, anything could happen between then. This virus is going to find people who are not vaccinated, who don't wear masks, and who don't maintain social distancing. That virus will find people. When you realize that so far in America, 1 out of every 12 people have been infected, and 1 out of every, it's just under 700 Americans have died as a result of this infection. This is what this virus does. And I think we're going to see just what they saw in the UK. Now, the question is, will it be outcompeted, for example, by the South African variant or the Brazilian variant, or a variant that has yet to arise? This virus doesn't stay the same. It just keeps mutating.
I know Dr. Fauci was saying that it seems like the vaccines that are approved in the US are effective against at least the UK strain.
So yeah, it depends on what we mean by effective. And let me just take you through that data. So if we look at the Novavax study, okay, the results just came out the end of this past week. If you look at the original strain that the vaccine was based on, it was about 95% effective. If you look at the UK strain, that effectiveness dropped to about 85%. If you look at the South African strain, depending on whether you were HIV positive or negative, it dropped to 50 to 60%. Okay, what about the mRNA vaccines? Well, all we can tell at this point, and more studies need to be done, is that the neutralizing ability of serum taken from people who received those vaccines is reduced about 6-fold or more against these variants. However, in the clinical studies, because these vaccines raise such a high and good immune response, it appears that people still are protected against severe disease and death, but not mild or maybe even moderate disease. Now, you might say, who cares about mild disease? Almost regardless of symptoms that you have, this virus can lead to long-term symptoms and complications in some people. So it turns out to be important. The second reason it's important is if it doesn't completely protect you, then you might not have severe disease or death, but you could spread it to somebody else who might.
Okay, last question for you. Thank you. This has been very helpful. Dr. Fauci was saying not to delay the second dose. I know Dr. Osterholm, we've kind of heard potentially different. Where do you kind of fall when it comes to that?
Well, the best data show that if we follow what was done in clinical studies, we don't go wrong. However, for practical reasons, many of us believe we should give as many people the first dose as we can and then worry about getting a second dose in. This is a race, and America needs to understand this. We are living through a race between virus and vaccine, between time and opportunity. So I believe we should give as many doses as we can, as quickly as we can. There are no examples where spreading out the interval doesn't benefit the immune response. It does. We don't have data specifically on COVID except for the AstraZeneca vaccine. And indeed, a longer interval leads to a better immune response. The flip side of that coin is that until you get 2 doses, you may not be protected.